welcome. Pleased to have so many of you here joining us today for this webinar. The International Menopause Society is presenting on cardiovascular disease. And I'm very pleased to have the opportunity to introduce our two presenters today, Dr. Professor Khoudary and Professor Cynthia Stuenkel. Dr. Stuenkel will be presenting via a pre-recorded video as the time zones prohibited her from being live with us today, but we're very pleased that she's able to be with us via that mechanism. Let me start by introducing Dr. Khoudary, who is a professor and vice chair for education of epidemiology at the School of Public Health, University of Pittsburgh. She is a cardiovascular epidemiologist with a long-standing expertise in coordinating multi-center observational studies and applying complex statistical methodologies. Her main scientific research area is cardiovascular epidemiology of the menopause transition, with a focus on mechanisms linking menopause, sex hormone levels, lipids, fat deposition, and subclinical measures of atherosclerosis in midlife women. Dr. Khoudary has received funding from NIA, NHLBI, and AHA to support her research, and has published numerous manuscripts, review papers, scientific position statements, and delivered presentations in various national and international scientific meetings. She has received several honors and awards, including the Fulbright Scholarship, the Trudy Bush Fellowship for Cardiovascular Research in Women's Health, New Investigator Award from the North American Menopause Society in 2012, the Best Paper of the Journal of Clinical Endocrinology and Metabolism in 2015, and the Early Investigator Award from the Endocrinology Society in 2016. She is an active member of the American Heart Association, the Menopause Society, and the European Menopause and Androgen Society, and serves on the editorial board for the journal Menopause and is the associate editor of the Journal of the American Heart Association and the American Heart Journal, plus Cardiology Research and Practice. Welcome, Dr. Khoudary. So I would now like to mention that this webinar has been supported by an unrestricted educational grant from Basins Healthcare. Basins Healthcare has no role in the selection of the topics or the speakers and has not vetted or reviewed the content of the speakers' presentations. Without further ado, we will move into the presentation phase, and we will allow participants to submit questions through the Q&A portal, and then toward the end, we will take questions from the audience.
Okay, thank you so much, Dr. Schnetz, for this introduction. And it's really my great pleasure to be with you today to talk about a topic that is close and dear to my heart on the World Menopause Day. And I will be talking about the cardiometabolic changes during the menopause transition. These are my disclosures. And for my talk today, I have three main objectives. I would like to start by reviewing why menopause has been linked to increased cardiovascular disease in women. And then I will spend some time focusing on summarizing the cardiometabolic changes during the menopause transition that we now aware of after many years of research. And then I will end up by reviewing the current recommendations for cardiovascular disease prevention in women. So menopause is a natural biological process that occurs in women's life, and it marks the permanent cessation of the menstruation and fertility for women. Once menopause hit, which usually happen retrospectively, once women have 12 months of amenorrhea, women marked as becoming menopause. And then research has been really characterizing women as either, premenopause before that time point or postmenopause. However, it's much more complex than this just kind of a definition. During the transition, women experience a decline in estrogen, and this is really the hallmark of the menopause transition. According to pooled data published on almost 234,000 postmenopausal women across 7 countries, we know that the median age at the natural menopause is 50, and early menopause happening usually when women reach menopause between the age of 40 to 45. That's about 7.3% of women, with a premature menopause marked if it's happening at an age younger than 40, and that's about 1.9% of the women. But we need to keep in mind that menopause does not happen all at once. And I'm speaking this way because, I am a researcher and I kind of read the literature and, envision how it has been looked over the years. Reaching menopause usually take over several years, and the experience itself is not the same. Women vary in when they start, the length they have experienced the menopause, and also the kind of symptoms they experience during the transition. I all the time like to share the STRA plus 10 staging system for reproductive aging in women because it's really speak for the complexity of the different stages the women experience in their life. And as you can see here, if you focus mainly on the green arrow, this is really splitting the women life into different stages. We have the reproductive, the menopause transition, and then postmenopause. Perimenopause is really the time when women start to experience changes in their bleeding. And the perimenopause average time, usually 3 to 4 years. However, it could happen in few months, and in some women, it could take up to a decade. But we know that the perimenopause usually extend up to 1 year after the final menstrual period. And this really time of women life characterized by multiple changes. And all these boxes you see on top of this arrow actually describe the hormonal changes as well as the symptomatology the women experience. And honestly, this is a speak for the complexity and the diversity of the menopause experience, among women, and call for studying the menopause transition as pre-menopause, post-menopause, making, us really not capturing this huge, diversity exists and variation from women to women. So age in particular is a very important confounder here. And we know that the prevalence of cardiovascular disease increase as we get older. And that's true for both men and women. And you can see that there is a significant sex differences in this prevalence early in life, which seem to be decline as we get older. And in particular, this happening around midlife, a time that tied to the menopause transition. Same thing you can see when you look at the incidence of cardiovascular disease. You can see also that usually men experience cardiovascular disease at twice the rate of women, with women especially at an age younger than 60, and women catch up with men a decade later. But the decline happening, or the decline in the sex differences happening close to midlife, again point to a contribution of menopause to the risk happening to women later in life. One of the earliest really findings that support a contribution of the menopause transition for cardiovascular disease came from the seminal work by Kennel, a group from the Framingham study, where they looked at 5,200 participants. Those are 29 to 62 in age, matched importantly on age. And it's very important to emphasize that they did a matching between those men premenopausal and postmenopausal group on age in order to remove the confounding by age. And the study showed that compared with age-matched men, premenopausal women usually at lower risk. And if you focus on the sex differences once women become postmenopause, this actually narrows down. If we just focus on comparing premenopause and postmenopause who were matched on age, you will see that the CVD incidence in postmenopausal women were more than double that for the age-matched premenopausal women. And this is more significant if menopause happened at younger age. So that really was one of the seminal work that proved a contribution of the menopause itself, independent of age in such a unique design. How we have been studying menopause in relation to cardiovascular disease really varied. And what I put in this slide, some of the mostly studied characteristics of the menopause or the menopause transition in relation to cardiovascular disease. Probably the age at menopause, one of the mostly studied characteristics, and the research up to this point has been really consistent, pointing out to that early and premature menopause would all the time associated with increase in cardiovascular disease risk. Type of menopause is another way of studying the link between the menopause transition and cardiovascular risk. And the main finding of the type of menopause, whether surgical menopause really related to increased risk of cardiovascular disease, found to be actually impacted by the age at which the surgery taking place, such that if we have hysterectomy with bilateral ovarectomy at an age close to the natural menopause, studies show that it has no risk associated with that. But if the bilateral ovarectomy happened at an age younger than 45, then there is a significant relationship with increasing risk for cardiovascular disease. For the rest of these characteristics, I will be sharing with you findings mainly from the study of women's health across the nation. And that's really a study of the menopause transition in the United States, contributed to our understanding related to these different characteristics that I will be sharing. So endogenous sex hormones, in particular estrogen, is the hallmark of the menopause transition. And as this audience aware, there are direct effects of estrogen on the blood vessels. We know that there could be rapid effect through non-genomic mechanism that actually impact the vessels in a way that lead to dilation through enhancing the production of nitric oxide. And there could be also longer term effects. These are more of a genomic impact that would result in actually decline in atherosclerosis and vascular injury, an increase in endothelial cell growth, as well as a reduction in smooth muscle cell growth. So the link in physiology, a physiological link exists there. What we have done in using data from the study of women's health across the nation, we were able to uniquely look at those women as they transition over 10 years before, 10 years after the final menstrual period, as you can see in this figure. And we use a statistical approach that can actually show us the pattern of decline of estrogen as women transition through menopause. Interestingly, our findings show that not all the women will experience the classic decline in estrogen as they transition through menopause. There are 45% of the women could actually experience a rise in their estrogen before a decline after the final menstrual period. The next step in our research was, okay, whether these different patterns would have a different impact on subclinical measure of atherosclerosis. And in particular, we looked here at carotid plaque. Interestingly, we found that women who experience a rise in their estrogen before menopause actually at lower risk of carotid plaque compared to those who experience a flat kind of decline in their estrogen, supporting a contribution here in endogenous estrogen in protection of subclinical measure of atherosclerosis. Another important hallmark of the menopause transition, which also has been studied to in link of cardiovascular disease, is vasomotor symptoms. And vasomotor symptoms experienced by almost 65 to 80% of the women. And in these slides, I'm showing or sharing with you, that actually the frequent vasomotor symptoms can actually, persist for up to 7 years here. That's the median based on this figure, but also it can last for up to a 12-year or longer. And the time through which women could, stay on the vasomotor or have these vasomotor symptoms could actually vary by race, ethnicity. With African American in particular, experience the longer, duration for vasomotor symptoms as compared to white in this slide. Similar to the hormone or to estrogen, we also looked at the trajectory of vasomotor symptoms as women transition through menopause. And we were able to show that women in their experience to vasomotor symptoms differ. Not all women experience the same kind of frequency of vasomotor symptoms. We have a group that would experience a high frequency of vasomotor symptoms, for all the time. We have a group who have an early onset of vasomotor symptoms that decline after menopause, a group that show a rise in their vasomotor symptoms up to 3 to 5 years, and then after menopause and then decline. And we have those, I would say, the lucky group, where they have some sort of a rise, but it's not as huge as other group. And then also we had the question of whether these different patterns of when the vasomotor symptoms happening and how long could also affect subclinical measures of atherosclerosis. And here we are looking at carotid intima media thickness, which a subclinical measure of vascular health. And we found that those group who experience early their vasomotor symptoms early in the transition, as well as those group with a high vasomotor symptoms, actually have higher thickness of the intima media as compared to those in the low onset. Here is our really reference group. Most recently, we also found that the vasomotor symptoms reporting is also related to cardiovascular event in midlife women. And as you can see here, frequent reporting of vasomotor symptoms associated with 51% increase in risk for cardiovascular event as compared to no reporting of vasomotor symptoms in this work. In addition to vasomotor symptoms, which is the hallmark of the menopause transition, other symptomatology the women experience could also impact women cardiovascular risk. And this really work is unique because we were able to use like more of a 56 questions about different symptomatology the women experience as they transition through menopause. These symptoms include psychosocial factors as well as sleep, mood changes, depression, in addition to vasomotor symptoms. And then we classify women using the latent class analysis into 6 subclasses with, number 1, show those group with many high intensity symptoms, include physical, psychological pain symptoms, poor sleep quality, fatigue. And with 6, show those with asymptomatic reporting or a few reporting of these symptomatology. The work here showed that midlife women with multiple high, moderate severity of physical and mental health symptoms are actually at higher risk of early onset of diabetes, as well as early onset of metabolic syndrome. So these symptoms also, the severity of the symptoms, how they accumulate, seem also to impact when women could experience any of these two, well-known risk factors for cardiovascular disease. Most recently, we looked at cycle length, and cycle length has been looked in the literature mainly in younger women. But here we looked at women transition through menopause, and we also tried to see if all the women experience, the same change in their cycle length as they transition through menopause. Surprisingly, really, for our, hypothesis, we found that actually 62% of the women could experience a stable pattern of cycle length over the menopause transition, and almost 21 or 22% would experience an increase in their length, in the cycle length, as early as 2 years before menopause, while the rest will experience a rise in the cycle length as early as 5.5 years before menopause. And similarly, we looked at whether the different patterns of the cycle length matter for subclinical measures of atherosclerosis. We looked at carotid intima media thickness, and we looked at pulse wave velocity, which is a measure of arterial stiffness. We found, interestingly, that the group of participants or group of women who classified to the late increase in their cycle length actually protected compared to the group who would experience a stable or a stable cycle length over the menopause transition. So I want now kind of a switch gear to talk more about the changes that the women experience as they transition through menopause. And the focus of this part of the presentation is really on the cardiometabolic changes that women experience and found to be more driven by the menopause transition. Again, I want to emphasize to this audience that age is a very important confounder because it's go hand in hand with women transition through menopause. So it's challenging to disentangle what could be because of aging and what could be because of the menopause transition. And maybe I should not actually use the word because again, this would imply causality. But what we can say that some of these measures seem to be more driven by the menopause transition, and I will show you based on what we make this kind of conclusion. So weight in particular and weight gain is one of the mostly studied, I would say, a change that accompany the menopause transition. And there has been lots of debate whether women gain weight because of menopause or because they just get older. And the research up to this point very consistently proved that it's aging driven, and it's just because if we get older. But what matters for the menopause transition is seem that the body composition and fat distribution is relevant to the menopause transition. And this is data from almost 1,200 participants from the SWAN study, where those women were followed over time, and we had done DEXA and body composition using DEXA on those women, where we looked at the fat mass and lean mass and looked at that over time, with 0 is the final menstrual period. Interestingly, we show an acceleration happening in the fat mass 2 years before menopause up to 2 years after menopause. At the same time, there is a deceleration in the lean mass taking place 2 years before menopause up to 1 year after the final menstrual period. The fact that we are not seeing a linear relationship telling us that this inflections happening around the final menstrual period is really more driven by the menopause transition. So women start to accumulate more fat and actually lose their muscles during the transition to menopause. And then the question we had whether a specific location of the fat would be impacted by the menopause transition. And here we looked at the visceral fat in the abdomen. And again, we looked at this among 362 women from an ancillary study of the SWAN, where we looked at the visceral fat measured by CT scans, and we followed those women over time. And again, we saw the same kind of an acceleration happening 2 years before the final menstrual period up to menopause, where women actually could have 7.8% increase in the accumulation of the visceral fat during this time interval. And then the follow-up question that we want to ask whether it's matter. So we looked at the relationship of the change in visceral fat in this period, which we then name as a perimenopause, and this period, which we then name as premenopause, perimenopause, and postmenopause in relation to carotid artery intima media thickness. And only the change happening during the perimenopause found actually to significantly associated with a thickness or a greater thickness of the intima media as compared to other changes happening during the transition, pointing out to this period as a specific period that an acceleration happening in such an important risk factor for cardiovascular disease. Where else in our body fat seem to matter? And this is a work that I have been really focusing on, which is the fat around the heart. And the fat around the heart can be split into two types: epicardial fat, which is the fat adjacent to the myocardium, and paracardial fat, which is the fat outside of the epicardial sac. And these fats are metabolically active in the way that they produce cytokines, inflammatory markers that can directly impact the myocardium. Our studies showed that women, postmenopausal women, independent of age, as well as other important factors include race, ethnicity, physical activity, alcohol consumptions, among others, usually have more actually of this fat as compared to premenopausal women. And this fat seemed to be also related to their endogenous estrogen, such as women with lower estradiol have actually more of this fat as compared to women with higher estradiol level. Blood pressure. Blood pressure is also an important risk factor for cardiovascular disease, and it has been, in question whether the change in blood pressure that women experience during midlife could be related to the menopause transition. This is really a unique analysis done by combining 4 community-based US cohort studies, almost 32,000 or 33,000 participants, 54% of those are females. To this side of the slide, what you are seeing here is really the level of systolic blood pressure, the diastolic blood pressure, as well as other measures of blood pressure. And to this side of the slide, you are seeing the change since baseline. If you focus on the level, you can see early in life that men usually have higher level as compared to women. And as we approach menopause, although not necessarily at that age, but women start to reach, the same level of men, and then they actually become, having higher level of systolic blood pressure. But when you look at the change since baseline, you see actually women have a greater acceleration in their systolic blood pressure as compared to men. So the fact that women have lower systolic blood pressure, as compared to men when they are young, maybe has a contribution to, when women usually start their treatment. But really, I found this follow-up work from the same group of researchers using these 4 community-based cohorts, where they looked at the cardiovascular risk associated with blood pressure in men in blue and women in red by decile of systolic blood pressure, really stunning, where you can see that the risk start for men when they have a level of 130 to 139, but for women, the risk is significant even at 100 to 109, again, pointing out actually that maybe we should not use the same cut point for defining blood pressure between men and women. And you can see the same pattern for cardiovascular disease, for myocardial infarction, for heart failure, for stroke. Men usually have the risk at higher level, but women start to show the risk at very early. Now, this is important because, in our studies, then we looked at the blood pressure as women transition through menopause. And we looked at the same time trying to see if all the women would experience the same kind of pattern as they transition through menopause. We found 3 patterns. 47% of the women would experience a linear pattern, which again, going hand in hand with aging. Yeah, we should experience an increase in our blood pressure as we get older. But 36% would experience a low level, but a significant rise as early as the menopause. And we have a 17% who, start high and experience some kind of decline. So this is really proof to us that, the change in blood pressure as women transition through menopause is not the same. Then we looked at what predict really these patterns. The low accelerated was of more interest for us because that's really what go with the menopause transition. And we found that women with younger age at menopause are more likely to experience this pattern, as well as other factors such as frequent vasomotor symptoms found to be associated with increase in the level of blood pressure, whether women were belong to this trajectory or this trajectory or that trajectory. What was interesting for us that estradiol was not associated with the level or with the pattern the woman experience. So pointing out that there are other factors that play, or could, contribute to the differences we are seeing here. Metabolic syndrome is a critical risk factor for cardiovascular disease, and the work we have been doing also show that the metabolic syndrome actually increase over the menopause transition. And I keep pointing out the linear versus inflection because that's how we, made our conclusion that this is really more driven by changes happening at that time point, of the menopause transition. You can see that there is an increase happening as early as 1 year before menopause for the metabolic syndrome for women. Lipids also another important risk factor that it change as women transition through menopause, and this is really seminal work done by our group where we looked at the low density lipoprotein, and we show a significant rise in low density lipoprotein starting 1 year before, 1 year after the final menstrual period. And in a follow-up work we looked at whether it matter, whether this change that happening has anything to do with cardiovascular risk. We looked at the relationship of the change happening with carotid plaque, and we found that the steep rise in LDL indeed associated with the greater risk of carotid plaque after menopause. HDL-C has been really something of interest to me in particular, and HDL-C, is the good cholesterol, and we are still using in clinical practice. Although I would say for clinical trial, that has been trying to increase HDL-C, the finding were really disappointing and never show that it's will produce the cardioprotective, expectation that we all think. For women transition through menopause, HDL-C has been really interesting because we couldn't figure out by reviewing just the literature whether it's going up, going down, or stabilized. Actually, this is all over the place. But when we looked at those literature, it seemed that those mainly driven by the design of those studies. In our study, we were able to follow women over 10 years of the final menstrual period. Indeed, we found that HDL-C decline around menopause, but then after menopause, there is a strike increase in HDL-C, which again point out, okay, so why women don't see a benefit from HDL-C? Our work actually suggests that HDL-C may become, or in particular, I would say HDL may become dysfunctional as women transition through menopause. This is a work where we looked at the relationship between HDL-C and aortic calcification by level of estrogen. Interestingly, we found that actually higher level of HDL-C associated with greater aortic calcification when women have a low level of estradiol, but it's showing you the expected protective association when women have a high level of estrogen, suggesting a potential dysfunctionality as women transition through menopause. So that's drive us to look at other measure of HDL. This is the HDL cholesterol efflux capacity. That's the direct measure of the function of HDL, removing the cholesterol from the periphery. And we found actually the relationship between um, the HDL particle, these are the particles that carry the cholesterol out to the periphery, and HDL cholesterol efflux capacity vary by menopause status, such that the capacity of the particle to move cholesterol from the periphery higher in the perimenopause as compared to the postmenopause, suggesting again that there is dysfunctionality happening to the particle as women transition through menopause. We use data from the MESA study, and this is a study of subclinical measure of atherosclerosis, where we looked at different subclasses of HDL, and we were able to point out that the large particle in particular seemed to, impacted by the menopause transition. And here we looked at the large particle in relation to carotid IMT by percentile and by the year relevant to the final menstrual period. You see that the closer to the final menstrual period, a higher large particle associated with higher carotid intima media thickness. So it's in the opposite direction, but it seemed that these particles kind of restore its ability to be protective later in life, suggesting some sort of dysfunctionality again happening close to the menopause transition and validating our work by using a different cohort. The menopause transition is a critical period also for vascular health. Our work here really focus on structural as well as functional changes, and we followed 249 women over time, over 9 years, and we actually calculate the time at which women spend in each of these stages, and then we calculate the progression of carotid intima media thickness at each of these stages. Strikingly, we found a significant progression in the carotid intima media thickness. That's a structural change in the vasculature happening in the late perimenopause, but not in the postmenopause. We found the same kind of pattern when we look at the pulse wave velocity. That's a measure of arterial stiffness, where we show a 5.7% increase in the pulse wave velocity 1 year before to 1 year after menopause. So suggesting that the vascular health become, vulnerable during the perimenopause, independent of many risk factors and confounder, we have included in our models. So I just showed you data, showing that the menopause transition actually is linked to multiple changes. These changes happening in the body fat distribution, these changes happening in the lipids lipoprotein, vascular health, as well as the metabolic syndrome. And all these are really critical to heart health. If you're familiar with how the American Heart Association has been measuring the heart health using what we call the Life Simple 7. These are 7 factors and healthy behavior that, if we maintain, we can, judge that we have a healthy heart. These are, living smoke-free, have a blood pressure that at the 120/80, maintain healthy weight with a BMI less than 25, cholesterol that is less than 200 milligram per deciliter, and the blood sugar that is less than 100 milligram per deciliter, and then being physically active with having a 150 minutes of moderate of intensity activity or 75 minutes of vigorous intensity activity per week, and making sure that we are eating healthy. That's, our diet include vegetables, fruits, whole grains, and fish, as well as the limitation of sodium, saturated fat, and added sugar. It is important to highlight that the American Heart Association recently it changed the Life Simple 7 into Life Essential 8, acknowledging sleep as a very important health behavior, I would say, added to the other healthy behavior that we need to, focus on. So the reason I'm pointing those out, because, the data I just showed you all point out to perimenopause as a critical time for cardiovascular cardiovascular health. And the accumulation of this data really pushed us to work together and write the first scientific statement on the menopause transition and cardiovascular disease, which was published in 2020, covering all these changes and much more related to the different behavior and how women seem to doing in relation to each of these at their midlife. So shifting gear here to guidelines for cardiovascular disease prevention, and these coming from the 2011, which was the last one that is more specific to women. After that, the American Heart Association just published a general guideline, but those guidelines, effectiveness-based guidelines, and put lifestyle intervention as number one, and then major risk factor intervention as number two, using therapeutic and pharma therapeutic, and in addition, of course, to behavioral intervention, and then preventing drugs intervention as number three. So it's not surprising that we focus on lifestyle intervention, because to me this is really a stunning data from the nurse health study we had many years ago. This is coming from 1980 to 1994 among 84,000 who were followed 14 years, showing that healthy lifestyle actually could prevent up to 82% of coronary heart disease if the participants stick into a healthy lifestyle that is being physically active, not smoking, weight control, and healthy diet simultaneously, not just one of these, but together. So it's proving that it's working, although this is an observational study, but still really, a strong kind of, data that we should take in consideration. What's really disappointing that when you go and look at the statistics, you find that only 21% of female older than 20 years have more than 5 of the healthy lifestyle metrics achieved at the ideal level. So definitely that's alarming, and that's telling us we have something in hand that is working, but not everyone is doing it the way we want them to do. Now, we try to look at the Life Simple 7, and this work was before the Essential 8 coming in the women in the study of women's health across the nation, trying just to see the status in those women. And we found actually indeed that women actually at midlife, only 18% of our cohort actually had 5 to 6 ideal components. So it's kind of similar to the national data, and even less than that. Again, underscoring the huge work that we need to do in order to push women more to stick into healthy behavior. But what also astonishing here, that almost 80% of the women classify as poor for their physical activity as well as for diet. And this is data at midlife, at the time when women experience multiple changes in their cardiovascular health. This data coming from the Chicago Health Association study, 25,000 participants, men and women, and classified, looked at their cardiovascular health at midlife and classified them as all of the different metrics favorable, at least one favorable, and then more than 2 favorable, and look at how that group, or how that related to all-cause morbidity and all-cause mortality. Interestingly, the study showed that favorable cardiovascular health at younger age could extend survival by almost 4 years, and could postpone the onset of all-cause as well as cardiovascular morbidity by 4.5 to 7 years. So that's again a proof that we have something in hand that is really working, that can really help and increase even survival in men and women. But today we are really focusing on women here. So when we talk about the guideline, definitely we have to kind of touch base on hormone therapy, given, that this is a really a topic that has been in study for way many, many years. And, the current guideline does not support using hormone therapy to prevent cardiovascular disease. And here I'm reviewing with you the history of the hormone therapy starting in 1980s, where all the observational studies were very supportive, showing that hormone therapy actually associated with a reduction in the incidence of cardiovascular disease, supporting the move into, testing that in clinical trials, which, where the results from the clinical trials, came disappointing. A lot of discussion, a lot of, publications came trying to justify, clarify what's happened. And we learned a lot that, we may not focus on the right women. We may actually, there are specifics, related to the age, in particular, at which women start using their hormone therapy. And it seemed that age matter. And here where we have, contemporary randomized clinical trial, including the KEEPS and ELITE trial. These trial focus on subclinical measure of atherosclerosis as the main outcome, and try to test what we call the timing hypothesis, that when we offer hormone therapy at younger age, it actually would provide more benefit than, risk. But additional work, I would say, from observational studies as well as real world data point out that we still really don't know to the level we want to know. In particular, we still really don't have clinical trial to focus on the different types of, estrogen, to focus on the different formulation, on the different route of administration, which these observational studies kind of, showing. And this is just, highlighting the hormone therapy timing hypothesis, showing that there is a specific time that we need to keep in mind, when we prescribe hormone therapy to treat vasomotor symptoms, so we are not impacting cardiovascular risk in particular. The timing hypothesis seemed to be, explained by, the different effect of estrogen on the vasculature. In that, we are seeing that, if we are offering estrogen at younger age, that's, when the vessels are more healthy, then you expect, more beneficial impact on the vasculature. Those increasing nitric oxide, endothelin would increase vasodilation, a reduction in lesion progression. But if we offer hormone therapy at older age, when there is an establishment of atherosclerosis, actually the estrogen receptors could be dysfunctional, and the hormone therapy could actually increase inflammation, and then of course leading to increased risk of thrombosis and coagulation. So I would like to sum up now. The menopause in particular matter for women cardiovascular health. Midlife women experience acceleration and adverse changes in multiple metrics relevant to the heart health. Midlife women should strive for heart-healthy lifestyle in order to counteract the menopause consequences and better control their risk of heart disease. Hormone therapy is the most effective treatment for vasomotor symptoms, genitourinary syndromes, and as well as has been used to prevent bone loss. The effect of hormone therapy vary by age, the time at which women start, as well as the comorbidity status. We know that if women start hormone therapy at age younger than 60 or within 10 years of the final menstrual period, the benefit outweigh the risk, supporting treating the other symptoms, vasomotor symptoms, as well as potentially could experience, significant reduction in their subclinical measure of atherosclerosis, lipids, and diabetes. But the risk could be higher for women if they use it at age older than 60, making it associated with more risk for stroke, venous thromboembolism, and dementia. The current finding also leverage and provide insights into the etiology. Finally, we have age at menopause as one of the risk-enhancing factors in the American Heart Association and American College of Cardiology. Also, the finding is alarming for health care provider and requesting them to evaluate their women at midlife for lipids, blood pressure, and making sure that they applying the risk equation when they try, for example, to prescribe statin. And finally, I want to emphasize on the importance of taking a holistic approach. And this is work just showing that the association of well-being matter on top of adjusting for cardiovascular risk factor. It's actually requiring us to take a holistic prevention approach that also includes psychosocial well-being. More work is now toward menopause and women's health. The Go Red for Women, they have their own website, they have their infographics. And in Europe, I was very thrilled to see this work by Mass et al. Group, where they show that the different stages of women's life, and here I'm focusing on menopause, and how we should deal with the different changes and what we should do in order to empower women during this time frame. And I know that the next talk will cover the different stages, so you will hear more about that. With that, I would like to acknowledge all the women contributed to the work that we have done, as well as the investigators that I worked with from different studies. And I would like definitely to acknowledge the funding from NIA, American Heart Association, and NHLBI, enabling us really to accumulate all this science. And with that, I would like to thank you all. And I believe, I'm not sure if we are doing the questions now. I will leave this to Prof. Schnutz, but thank you so much for listening.
Thank you so much, Dr. Khoudary. And go ahead and introduce Dr. Cynthia Stuenkel, and then we will move into the presentation phase. Dr. Stuenkel is the clinical professor of medicine at the University of California, San Diego School of Medicine, and an attending physician for UC San Diego Endocrinology and Metabolism Service. She attended medical school at the University of Illinois, Chicago, with residency training at the University of Chicago and the New England Deaconess Hospital, with endocrinology training at the Endocrine Hypertension Division of the Brigham and Women's Hospital, affiliated with Harvard Medical School, and reproductive endocrinology at the University of California, San Diego. In 1988, at UCSD, she established one of the first menopause programs in the U.S. A founding member and past president of the North American Menopause Society, Dr. Stuenkel has contributed to the NAM's hormone therapy position statement since 2007, including in the most recent publication in 2017. She chaired the Endocrine Society's 2015 clinical practice guidelines on treatment of symptoms of the menopause and spoke on behalf of the Endocrine Society at the FDA workshop to review the labeling for low-dose vaginal estrogen therapies. She is a participant in the 2019 International Society of Women's Sexual Health consensus panel on testosterone use in women, and she is the author of the International Menopause Society white paper for World Menopause Day, reproductive milestones across the lifespan and cardiovascular disease risk in women.
Hello, I'm Dr. Cynthia Stuenkel, and I'm very pleased to be here today with you. I wanted to just mention that I sit on a data and safety monitoring board. That's my only disclosure. And I am so pleased to be here to participate in World Menopause Day. It was a great honor for me to be asked to do this, and I want to thank the IMS board for selecting me for this honor. I wanted to recognize Professor Stephen Goldstein, who was the first one who talked to me probably a year and a half ago about this possibility, and Dr. Rodney Babar, who really has helped to usher through the process of both the white paper and some of the details related to this presentation. I was very pleased that we were focusing on cardiovascular disease in women. I think this is an incredibly important arena and one that really just is going to make all the difference in the lives of women and our patients. The focus of this white paper, though, you might go, well, we're the International Menopause Society. So why are we talking about things like reproductive milestones across the lifespan? And it's because I really thought that over the last 5 years or so, that this information has been compelling and emerging evidence that the cardiovascular health of women, when we see them at midlife, really is reflecting a number of reproductive events that have occurred over their lifespan. So, the goal of my presentation today is to review the impact of cardiovascular disease in women, um, consider the spectrum of cardiovascular risks, which are really growing, highlight female reproductive milestones in terms of how these might relate to future cardiovascular risk, and then finally just review some of the recommendations for minimizing the risk of cardiovascular disease in women. So there's no question, starting with the World Heart Federation, that cardiovascular disease, which include the common clinical manifestations of heart attack and stroke, is the leading cause of death in women worldwide. Women with cardiovascular disease, however, continue to be underdiagnosed and undertreated due to misconceptions. I don't know whether they're vulnerable to cardiovascular risk, whether they're presenting with cardiovascular risk because the symptoms may vary, whether they just don't think it can happen to them or we don't think it can happen to them. And then just the lack of awareness that this is an ongoing, critically important issue. Again, just this number, 1 in 3 deaths in women is caused by cardiovascular disease. I hope you had the chance to encounter this Lancet Commission piece on women and cardiovascular disease, with the goal of reducing the global burden by 2030, just around the corner. But the authors of this commission are really powerful, inspiring women, leaders in the world of cardiology, and I think really took the mantle of this to heart themselves, because this discusses not just some of the general things we think about with cardiovascular disease, but really takes a global approach. So, wherever you may be, think about taking a look at this. And these are some of their just bottom line points. Number one, women with cardiovascular disease, again, understudied, underrecognized, underdiagnosed, and undertreated. Sex specific mechanisms in the pathophysiology remain poorly understood. So much of an arena for more research. Myocardial infarction and cardiovascular disease mortality, this scares me, are increasing in younger women. So the kind of risk factors that we see in these younger women, more obesity, hypertension, diabetes, it's happening. It's taking a toll. And I kind of worry you, as these young women, by the time they get to menopause, may often have had cardiovascular events. And then sex specific and other underrecognized risk factors, and I'll talk about some of those in a minute, do contribute to this global burden. So lots to learn, and miles to go before we sleep. I don't know where in the world you may be watching from, but I think maps like this are always really interesting. I think all of us like to compare, where am I on this? And I'm over here in San Diego, California, but you can see that the region of the US is an orange. This says we're getting up there, as far as the prevalence of CVD per 100,000 patients. Maybe one of you are living in these cool blue areas where the numbers aren't so high, but there's no question that if we look at this map 5 years down the line, we're going to be seeing more of the warm colors and less of the cool. The American Heart came out and just said that, we were doing pretty well for about 4 decades, and the rates of CVD were declining, but that benefit is now decelerating. Or I've talked in the past about stagnation as another word. In other words, we're backsliding, we're going downhill, and we've got to notice this and do something about this. These adverse trends are observed in women. They're also observed in men to some extent. But I think women are more vulnerable to some of the disparities by race, ethnicity, and sadly, when we look at care disparities versus men, these are still there and have been there for more decades. So integrating women-specific risk factors into quantitative risk assessment across the lifespan is a goal. It's necessary. It hasn't happened yet, but I think we can still at least be aware of these events and build them into our care plan and our consciousness, and we can build them into our perception of risk. And some of you have seen me use this slide before. I always use this slide because I think this concept is so important. If you don't really buy into this, that your patient's at cardiovascular risk, it's unlikely that you're going to really recommend preventive strategies. If she doesn't buy into it, when you tell her you're at cardiovascular risk, then she's not going to try to take better steps towards a healthier life. So this perception of risk is something that we really need to work towards gaining. So what are these risks? And I've taken them as laid out in the Lancet Commission. You could find a little bit different groupings in other expert groups, but nevertheless, I think that this is a very good way to be thinking about these things: the well-established risks, the under-recognized risks, and then finally sex-specific risk factors. So everybody's familiar with these. These are the kind of considerations. If you do a risk calculator, is going to ask you questions about this. And I was surprised to see in the New England Journal of Medicine yesterday that according to the Global Cardiovascular Risk Consortium, so we're talking global, about 60% of cardiovascular disease in women might be attributable to these key risk factors that we know about. But that says to me that's 40% that we haven't explained. So we have to look to some of the under-recognized risk factors. We know that women may be more vulnerable to psychosocial things like depression, just the incredible stress of living in an abusive or a violent relationship, and then so on and so forth with ills of our societies, ills of our healthcare system, ills of our world that can factor in. But when I read these and think about stress, it really reminded me of the Interheart study that reported its findings maybe a couple decades ago now. But what really stood out to me was the idea that stress for women, and they just said, "Are you stressed?" They didn't have some special, check off the box to calculate it. Just, do you perceive stress was a stronger risk factor than diabetes? Think about that. That's a profound thing. And then finally, the sex specific risk factors, which is what I want to talk about today, um, include a number of things. Like at the top of the list is premature menopause. So that's something that we're very familiar with. But also, in addition to that, the adverse pregnancy outcomes, including gestational diabetes, the hypertensive disorders of pregnancy, and systemic inflammatory conditions, these have been recognized in some combination or another by the World Heart Federation, the European Society of Cardiology, the US cardiology groups as, quote, risk enhancing factors. So it doesn't mean that we can say add 25%, add 10%, whatever, but just saying that we should pay attention to these. And if these risk factors are present, then that means that as we make an assessment for that woman going forward, we have to dial up her perceived risk or our calculated risk by a couple levels. And so I don't know if you've had the chance to see some of these papers. I would say over the last 5 years, there has been a real burgeoning number of studies, of consensus documents. And one of the things that I find really exciting that this paper really, I think, underscores is the need for interdisciplinary collaboration. You're seeing cardiologists, gynecologists, and endocrinologists. I'm an endocrinologist, so I like to see that on the list. But and a number of the U.S. papers have also focused on this, and the Lancet Commission, the Global Commission, focused on this. We've got to start working together more. And then the final thing that I find kind of intriguing as these papers present this data is looking at the spans across the lifespan, starting in childhood with things like menarche, looking at a number of conditions that I know you're familiar with in your work. I'd say the two big ones are adverse pregnancy outcomes and some of the various issues about menopause, which I know you've just heard a fantastic presentation from Dr. Khoudary about this. And so I'm not going to be going into that in great detail, but I have a couple things that I wanted to include. And so what I thought we'd do, I tried to cover these in a fair amount of detail in the white paper. What we're going to do today is kind of have a brisk run through a number of these things just to kind of increase your awareness and see if some of them might be new to you that you haven't heard about before. So again, mindful that usually, at least in the past, heart attack and stroke came on in the 60s and the 70s, but this gives us this entire reproductive lifespan to look for unique risk identification and hopefully intervene early in risks. And I like to say, let's open the window of opportunity to optimize cardiovascular health in women. So let's begin with our run through. And this is looking at the menstrual cycle as a window. A menstrual cycle. It seems kind of mundane, seems as it's something that should just be happening. But I really like this committee opinion that ACOG put out, I don't know, 15, almost 20 years ago, where they said that regarding menstruation in girls and adolescents, that we should be using the menstrual cycle as a vital sign. I tell this to our residents, I tell this to our fellows, I tell this to our medical students. Ask about the menstrual cycle, and you've got to know what's going on. Certainly, if your field is gynecology, that's something that you're like, this is routine. But for those of us that didn't necessarily get brought up that way, we might not be thinking about it as much. This is just one example of one report that looked at menstrual cycle regularity, the length of the menstrual cycle across the reproductive lifespan, and then said, does this have any bearing at all on the risk of premature mortality? This was from the Nurses' Health Study, which I think probably most of you are familiar with as a prospective cohort study. Almost 80,000 women who started with a pretty fresh start, no evidence of cardiovascular disease or profound risk factors. And they just asked them, tell me about your menstrual cycles at these ages at the time that they were enrolled and being followed. And then they looked for another couple decades to see what happened with mortality. And the bottom line was that they found an association, particularly between those who had very irregular or absent menstrual cycles, very long cycles. And it was about of the magnitude of a 22 to 50% increase in premature death, but still associated with irregular menstrual cycles. They did all the appropriate adjustments. And I think this confirmed, and there have been certainly other studies that have looked at this, that regular menstrual cycles are indeed a marker of good health. And I'm glad that ACOG said we should think of them as a vital sign. So one group of women that we know do not have regular menstrual cycles are the women with polycystic ovary syndrome. And this, I think, is another window into cardiovascular health. We know that these women have, a number of them have the metabolic syndrome. They may start with individual cardiovascular risk, but they seem to kind of coalesce, complicated by hyperandrogenism. And we've had studies for some time that have looked at subclinical risk in these women, but I think there's been maybe a little bit of a date of really being willing to, you know, put that stake in the ground that these women are at increased risk for cardiovascular events. This is just one meta-analysis I wanted to show you that talks about the rate of ischemic heart disease in women with polycystic ovary syndrome. And just going right to the bottom line, you can see that it's, substantially to the right of 1, and the odds ratio for this was 2.77, almost a threefold risk of ischemic heart disease events. And so I think it's of no surprise then that the 2023 International Evidence-Based Guidelines came out very strongly stating that PCOS should be included as a cardiovascular risk factor, should maybe be included, like we're talking about some of the pregnancy events and the assessment tools. Women with PCOS, when you're seeing them in your office, should be considered at risk of CVD and maybe CVD mortality. And they should be assessed and counseled about cardiovascular risk factors. And from the get-go, from the earliest time that you see these women, we need to be discussing and prioritizing preventive strategies for them. The next group I wanted to touch on was infertility. This was sort of a newer one, and this came up as maybe a little bit of a surprise. This is a paper that was earlier this year, again from the Nurses' Health Study. And I was also surprised that about 1 in 4 of these women reported infertility. So the findings were that there was a greater risk of coronary heart disease, not huge, but significant. The earlier they knew that they were infertile, the higher the risk. And I found the causes of infertility to be pretty interesting, particularly endometriosis being listed. Hugh Taylor was at the Menopause Society meetings in Philadelphia last week, and we were talking, and he said, of course, endometriosis is a disorder of inflammation. So it really makes sense that, like some of the other standard inflammatory conditions like rheumatoid arthritis or lupus, that increased inflammation would be associated with an increase of cardiovascular disease. So I thought that was an interesting one. The one that I mentioned that has a lot of attention is that of pregnancy, and pregnancy as a window into cardiovascular disease. And this is one of the earlier figures that I saw when these papers started coming out about 5 years ago. But I like it because in one picture, it tells so much of the story. So starting at the top panel, when women are pre-pregnancy, they haven't conceived yet, but, we see this constellation of risk factors, and we're seeing more of these. And I know you're seeing more of these in your young women in your practices. Um, and then there's a number of things we can't see or necessarily measure in the office that we know are there. That may impair their hemodynamic adaptation to pregnancy, that are associated with endothelial dysfunction, leads to placental dysfunction, and again, inflammation, inflammation, inflammation. So during their pregnancy, then we're seeing the hypertensive disorders of pregnancy, gestational diabetes, and then a number of issues that relate to the well-being of the fetus and the outcome for the offspring. And so these are very disturbing as well. And again, postpartum men, these women may have ongoing endothelial dysfunction. There's some thinking that maybe pregnancy is just a stress test, another really powerful stress test that unmasks some of this pre-existing risk that may already be present in these women. And finally, again, inflammation, so that we see in these patients, if we're paying attention and they're not lost to follow-up, things like hypertension, diabetes, obesity, metabolic syndrome, and again, all adds up to cardiovascular risk. So one thing that came to my mind as well, I've been telling you about some of these other reproductive milestones that have an increase of 20%, 40%. What kind of risk do we see in women with these pregnancy disorders? So this was a really, I think, powerful umbrella review, all these meta-analysis and reviews, 8 to 10 years follow-up, and looked at different categories: composite cardiovascular outcomes, ischemic heart disease, stroke, and then heart failure. And here's what they found. We're not talking 10 or 15 or 20% anymore. We're talking 300% when we look at women who've had recurrent preeclampsia, an incredibly high risk group, and one that increases the risk of heart failure in a powerful way. A twofold greater group, and again, preeclampsia is a tough one. Preeclampsia might be one of the most challenging from a cardiovascular systems-wise thing, with a twofold increase in composite outcomes, twofold increase in ischemic heart disease, twofold increase in stroke. Gestational hypertension, not so bad. They also include in this table some of the consequences with fetal implications, a preterm birth, these 50 to 90% increase. And then some of the ones I showed you earlier, like early menarche, PCO, comes into the maybe less than 1.5-fold risk. And then the good news for patients that ask, what are the benefits of breastfeeding? Well, longer duration of breastfeeding reduces cardiovascular risk. I'm not sure we emphasize that enough. So these pregnancy risks are serious ones, and I think they're ones that we really need to embrace. I wanted to just make a comment on this paper that came out this year, because they talked about not just optimizing pre-pregnancy health for outcomes in pregnancy and postpartum, but also thinking about outcomes in the offspring. And I've talked about some of the, terrible events that can happen, but there are other consequences. So here's our young girl in her adolescence, pre-pregnancy. We know what we're seeing, at least in the US society, about obesity, tendency towards diabetes, maybe some hypertension even by young adulthood. She becomes pregnant. She has an adverse pregnancy outcome. And then we anticipate that somewhere between middle life and older age, that she may present with a cardiovascular disease, which is kind of a consequence, we're learning, of those adverse pregnancy outcomes. But I wanted to point your attention to this graph, which I really hadn't seen so many uh, other reports that really called attention to it in this way, because I'm talking about the inflammation, the hemodynamic changes during that pregnancy. Here's this person who's experienced that whole pregnancy. And so following birth and early childhood, we need to keep an eye on these patients as well who have also experienced this adverse pregnancy outcome. And it was interesting to me, there was a study, a Danish study that came out earlier this year that said women with hypertension in their pregnancy had offspring that tended to have more diabetes. And so we're kind of tending to see some of these metabolic carry throughs into the next generation. And so the cycle begins again. And I'll come back to talking about some of the lifestyle measures that we may need to be instituting in our children as well. So, what all this has led to, and I think this is very positive and may also reflect some of the increasing numbers of young women cardiologists that are looking at this, is the whole concept of cardioobstetrics and having a team that follows women through this entire life cycle of pre-planning, of pregnancy, delivery planning, postpartum, to make sure that they don't get lost in the cycle and to make sure that they're appropriately monitored. So let's turn to breast cancer in a window. This is, not necessarily, you could say, how do you really consider this in the reproductive milestones? But I think we know that our treatments can cause reproductive havoc in a lot of our patients with breast cancer. But even going a step earlier, one thing that I hadn't really appreciated was how shared risk factors can be important for breast cancer and heart disease. So we need to think about that. We've learned, and I think this part is really interesting, how we put this perspective on, oh, she has breast cancer. In certain groups of women, we're doing a really good job getting them to 5 years after their diagnosis, doing well. And here's breast specific mortality at that point. And here's other mortality, sevenfold greater risk of other causes of mortality than their breast cancer, of which a third of these are from cardiovascular disease. We don't see this so much with women at higher stages, younger, and they seem to maintain their breast cancer uh, mortality predominance. But think about that. Think about that. We do a good job. She gets through her cancer, and now she might have heart disease. And if we look carefully at the breast cancer therapies, I think we can explain some of this. We know that induced ovarian failure can occur and the issues related to that, but there are direct cardiovascular injury that can contribute to heart failure with chemotherapy. Radiation therapy can cause injury to a number of different parts of the cardiac anatomy, but we're learning in the last year there have been reports that women who have left-sided breast radiation therapy might have as high as 2.5-fold increased risk of cardiac events on that basis alone. And finally, the endocrine therapies, particularly aromatase therapies, can contribute. So just as I was talking about cardioobstetrics, cardio-oncology can be important. I just wanted to show you just quickly, this was a comparison looking at SERM therapies, adjuvant therapies versus AI. And with the SERM therapies like tamoxifen, we do see an increase in venous thromboembolic events. But look at all the red with aromatase inhibitors. We see increase in risks like hypertension, dyslipidemia, metabolic syndrome, and we see increase in events. So, just being mindful that we're doing our best to preserve these women's health, but there are other costs in treating their breast cancer. So screening for and identification CVD risk factors are important. Promoting healthy lifestyle from the get-go is important, both for benefits to their treatment as well as, good data that it helps reduce recurrence. If a woman has a history of treated breast cancer, we're not done with her. We need to keep working on this going forward. Keep in mind that a cardiology team might be helpful depending on how she was treated and her current clinical situation. So in the final moments, I wanted to turn to menopause as a window. And when putting together the consumer information, I said the cardiovascular risk represents a lifetime of choices in how we live, experiences. I maybe should have added our genetic proclivity, but menopause offers the opportunity of a single point in time to step back, take stock, and do all you can towards promoting future cardiovascular health, really for the rest of your life. And again, I know so many details of what happens at the menopause transition and cardiovascular risk have already been presented. I wanted to touch just briefly on reproductive lifespan and make a comment about hormone therapy. So again, the reproductive lifespan, menarche to menopause, around 40 years. But we have learned that cardiovascular risk increases when that reproductive lifespan decreases, and that would be associated with an age of menopause at less than 40 years. And so this was another large analysis looking at 15 observational studies, 300,000 women that identified higher risk in women with premature menopause. And let me just show you how those ages laid out. Here's the age at natural menopause. So I'm not talking about surgical menopause here, just natural premature menopause. And the women less than 40 are at the top. You can see that they had about 4 events per 1,000 person years relative to like a premenopausal rate of 1.1, and that their risk overall was about a 50% increase, which goes along with what we've been looking at. One question that always comes to mind for me, though, is, which is the chicken and which is the egg? So we're talking with the International Menopause Society. You're saying it's estrogen deficiency. Of course, this is related to estrogen deficiency. But I think we need to be open-minded when we look at some of these risks as to whether they really might also have some shared origins, or, genetic is getting a lot of attention, leading to premature aging. So I think there's some really exciting research going on this, looking at telomere length, looking at CHIP, this clonal hematopoiesis of indeterminate potential, provocative with links of early menopause and heart disease. So I think more to come in this arena. For women that have experienced early menopause, there's no question that literally all expert groups, and Ann Gambella and I highlighted this in our recent piece, that in the absence of contraindications, and in this setting, I do call it hormone replacement therapy, should be given. It should be initiated soon after diagnosis. We recommend higher doses for these younger women, trying to emulate levels in menstruating women, and recommend that they keep taking it until the time of natural menopause, when we can reassess and then decide about continuing in the future. I was very intrigued to see the data from the WHI looking at MHT and mortality. This was particularly in women, and now I am talking about surgical menopause, who had BSO, and as the age got younger and younger, the mortality benefit increased for those on CEE alone. So I think, again, this is an impetus to make sure that we are identifying these women, and unless they have contraindications, to make sure that we're treating them. I like this slide because you can just sum it up and say there's been a long and winding road about the hormone story, and how we should and shouldn't be doing it. I think right now I'm very comfortable saying that looking at hormone therapy for women who, and you all know these mantras, who are under the age of 60, 10 years since menopause, who we've ruled out contraindications, evaluated their cardiovascular disease risk, and if they're low risk, sky's the limit. If they're intermediate risk, we recommend transdermal therapies. And then just be mindful that as the risk increases, and I think we might be seeing more of this increased risk by the time they become menopausal, that we might want to consider other options. I wanted to turn then to, just in the final moments, just talking about healthy behaviors. I lifted this from the new Life's Essential 8. This used to be Life's Simple 7. What has been added on is recommendations to get healthy sleep. And I think these are things that we know and our patients know. They honestly do work. We need to do them, at least in the US. And I showed you we're in that orange color because the prevalence of ideal cardiovascular health, I'm kind of embarrassed to tell you this, is less than 1%. And even if we look at our kids, if we look at, prime of life, teenage years, only half. Here's women getting pregnant, only a third. Here's women approaching and going through menopause, 1 in 10. And by the time we hit our golden years, 1 in 25. So miles to go before we sleep. And just remembering that I've been talking about heart disease, but there are a lot of benefits health-wise for these better living and who doesn't want to maintain cognitive function, have a longer health span in our golden years? So the bottom line is that clinical education has to emphasize risk factors. Again, I'm so proud and pleased to be able to participate in this World Menopause Day. You know, interdisciplinary collaboration, we get more done when we work together. And finally, research, awareness, we're all aware of these. And depending again on your particular country, have a look because they did a very good job in that Lancet consensus of identifying geographical priorities. So with that, I'll close. Thank you so much for your attention. Thank you so much for this invitation. I hope you look at the white paper, and I hope you think about cardiovascular disease in women. Thank you.
And for now, we will take Q&A from Dr. Khoudary. Do we have some questions that have come in? Here's one that asks if you've looked at the fluctuations of estradiol in each cycle in the transition and CVR. Have you looked at the fluctuations of estradiol in each cycle in the transition and CVR?
Yeah, I'm sorry. Can you repeat the question again? I'm sorry.
Have you looked at the fluctuations of estradiol in each cycle in the transition and CVR?
Oh, yeah, that's a very, very great question. We do have the daily hormone study where we actually had estrogen metabolite from women over a menstrual cycle. We looked at the fluctuation in those, and we looked at that in relation to the metabolic syndrome, and we found some kind of similar association, but we were not able to, or we have not yet, I would say, look at the pattern and changes as we have done for the blood coming, for the similar to the estradiol that we have done coming from the serum itself. But we are showing a similar relationship with metabolic syndrome, at least for these fluctuations.
Great. This one talks about the pointed out fantastic webinar, but then wonders whether the fact that HDL becomes dysfunctional over the menopause transition means that the use of the Q risk algorithm for women is misleading.
That's a very, very good question. And that's, I would say, one of the main goal of, our research here, since the HDLC is not seem to be consistently protective. And I agree with whoever asked the question. HDLC is part of the metabolic syndrome criteria. HDLC is part of the risk equation. And, this is pointing out that, for women, we may need to do something different. We have to reevaluate this risk in particular. I want to point out, I believe that we start to take this kind of action. The Life Essential 8 actually now is not using total cholesterol as the way to measure lipids. They are using non-HDL cholesterol as a way to measure, the risk. But for women, I totally agree with the question that, we need to reevaluate. We need to make sure that we are using the correct metric that reflect the cardioprotective capacity of HDL. Yes, I think we need more work on that.
So related to that, can you tell which parameter is more important, increasing HDL or lowering triglyceride or LDL for reducing the cardiovascular risks? And they mentioned that they know HDL is dysfunctional and different high risks. HRTs have different effects on HDL as well as triglyceride and LDL.
So definitely the LDL is, very important. And that's why it's there. And that's why we focus on, it when we look at statin use, and the triglycerides kind of play a role there. And I would say that for HDL, Mendelian randomization proved that there is no causal relationship. But the Mendelian randomization done really for HDLC. HDLC is just a metric of measuring the ability of the particle to remove the cholesterol from the periphery, the total cholesterol carried, by these particles. That's what HDLC. So I want to emphasize that, I'm not saying that HDLC is more important, no, but I'm saying that, as one of the, metrics used in the risk equation, we need to understand its contribution, because that's how we push to, use metrics that matter for women, and making sure that we are measuring the risk of those women to the level, that it reflects, the risk for those women. But definitely, I would say LDLC is more important, and we have way more evidence supporting its important link to cardiovascular risk in women and other than women.
Yeah. Can you comment on women with long-standing non-treated hypothalamic amenorrhea and the associated cardiovascular risk? Long-standing non-treated hypothalamic amenorrhea and the associated CV risk.
I worry that I don't have, information about that. But the data that we have, and I would say my group have been focusing on, is really the premature, which I'm not sure if that's what the question is asking about, but we know at least that the premature menopause definitely have a higher risk, justifying actually, providing hormone therapy for those, women up to the age at which we expect them to become natural menopause. So there are a strong relationship between premature menopause and, increased cardiovascular disease risk. But maybe I'm not, aware, or myself, maybe there is something there out in the literature, or maybe I'm not understanding the question to the level I should.
Yeah, I think part of it too is it may be related to the premature ovarian failure and early hypoestrogenism that you talked about earlier in terms of increasing the risk, and certainly from that standpoint, we know that early hypoestrogenism, whether it's true ovarian failure or whether it's periods of time with hypoestrogenism, that would increase that risk.
If I can add, if you recall the slide which I showed you, that 45% of the women in SWAN show a rise in their estrogen before it's declining. Actually, the fact that we show that the group with the rise before in their perimenopause time, rise of estrogen, more protected, supporting, that yes, if there is a hypo, estrogenemia in that time, definitely it could actually lead to a higher risk. The finding we show that the more estrogen you have before menopause, the more protection you have.
Yeah, great. Why is there more reluctance in starting, and I'm not sure what they were saying here, anti-HT, as well as statins and metformin in women compared with men, especially around the menopause? So why is there more reluctance in starting hormonal therapy or anti-hormonal therapy? I'm not sure what that is. Statins and metformin in women compared with men, especially around the time of menopause.
So I'm not seeing patients, so I will not be directly able to answer this from a clinical point of view. But if I understand the question, is the question more about why all this thinking we have to do when it's related to hormone therapy, but we kind of go ahead and give people statin, metformin, if they need it. I guess I will take a step, and then please, professionals, you can provide your thoughts. For the statin, we have a really a strong evidence from the, randomized clinical trial, making it straight cut, for, clinicians to provide, recommendations and guidelines. But for hormone therapy, the problem that really we couldn't prove the hypothesis that has been for many years, and that's why, it's more complex.
Yeah, and I'm not sure if the question is based on data showing that there's less use of medications in women, and if that's the case, I don't think it's related. Well, it shouldn't be. Let's put it this way: it should not be a reluctance to use in women. Women should be treated as much as men who are at risk for the same, if they have hypercholesterolemia or hypertension and so forth. In fact, you pointed out some data showing that women may even benefit starting antihypertensives earlier. So clearly there shouldn't be any reluctance to starting in women. I think part of it gets back to the age-old problem that we need to make sure people understand that women are at as high risk for heart disease as men, but that sometimes their presenting symptoms are different. But when you get into the postmenopausal years, actually more women die each year than men of cardiovascular disease. So again, I'm not sure if this is based on statistics of how many women are treated, but there should not be a difference. Can you compare men and women's responses to statins, aspirin, and ACE inhibitors in relation to prevention of heart disease?
So I know from the literature that, the, evidence for statin has been, more clear for men, but for women, the evidence has not been as clear as that for men. And the reason for that we really don't have the number of women, the participation from women in that perspective, even when they did a large kind of a polling analysis, trying to see if there is a difference, and there couldn't be, a support for, a contribution or benefit in women in particular. But I think that there is definitely a lack of research at the age group that we are focusing on here, in particular midlife women, and the women who experience the changes. So that definitely would require, more research from us in order to, get a better understanding of the contribution or the benefit for the women. And that could be, one of the reasons for why we see that kind of, publications coming showing under, a treatment that women undertreated, because we really don't have the evidence, and it could be related simply because of how we conducting the trials that we are dealing with now. I'm not sure if you want to take the other part of the questions.
Yeah, no, I think you handled that appropriately. Is that one thing is that we do need more data on the differences between men and women, and we know that for years a lot of these studies have been done predominantly in men. So we're starting to get more data, but that's a huge area of need is to tease out, because again, as you pointed out with hypertension, there are differences, and it's not appropriate to just look at one population and assume that that's the same across. And the differences that the hormones have, and seeing the difference from premenopause to postmenopause, these are really important, and so I think that's important to keep in mind. Are there studies about the increased risk of thoracic aortic aneurysms in menopausal women and the benefits of hormonal therapy? So I'm not aware of any data showing that hormonal therapy would either increase or decrease the risk of aortic aneurysms. And obviously you touched on the data, the timing hypothesis, and the role of estrogen in terms of endothelial function. So, it's an interesting hypothesis in terms of whether helping promote the endothelial function has a beneficial effect on an aneurysm, but I'm not aware of any data looking at that.
Yeah, same here.
Let's see, someone from South Africa. The topic is prevalence of metabolic syndrome in peri and postmenopausal women at a tertiary institution in low economic setting. I have noted a rise in CKMB levels, more especially in perimenopausal women. Did you assess it in your research?
No, we did not, but this is interesting to hear and to learn. The more we are, learning, it's definitely pointing out to the, perimenopause as a critical stage. And again, pointing out to this as a window of opportunity for us really to act, where we are seeing multiple changes, and you are now just, adding something from your work, which is interesting to us, and we may able to look at it in a future work for sure.
Good, excellent. See, okay, so it was just Manju was pointing out that the anti-HT that was in the question earlier was referring to antihypertensive, not.
Okay.
So the question was, why are women not started as quickly on antihypertensive statins? And we kind of discussed that already, and re-emphasized that women are not started on statins as easily compared to men. And again, I think that should not be as the take-home point. Why that is, I don't know, other than the fact that I think we need to make sure people are aware that women are in need of the same aggressive treatment as men, and it's a good observation that should not be the case. It has something been recent that the NIH has mandated that sex is a variable in studies. So in line with what we were just talking about, do you feel it would be valuable to also assess studies according to the women's menopausal status? And yeah, go ahead. I think, clearly, I would feel absolutely, is that age is one thing, gender, male, female, and is important, clearly. Age is also clearly important, but menopausal status, and you saw some data pointed out earlier from the Framingham that regardless of age, the pre-postmenopause has a dramatic effect on that. And so, yes, I think absolutely. Now, part of the problem is that as you dice out these variables, you need larger populations of studies so that you can still keep your power to show differences. But in the ideal world, if we can have a large enough cohort and look at age, menopausal status, as well as gender, then that's the ideal.
Absolutely. Yeah.
All right. Well, we're perfect timing. We've gotten through the questions in there, and we're right at 15 minutes past the hour. So I want to thank everybody for tuning in and being a part of this symposium. And thank you to our audience for being with us today. You take care. Have a great rest of your day, and hope to see you soon.